Now I'm happy to introduce Dr. Andreas Bartsch from Heidelberg, and he'll be talking about reporting on clinical fMRI exams.
Thank you, Susan. So my task is now to catch your attention for reporting, which may be boring if you don't write reports. But I hope, nevertheless, to convince you that having a fMRI reporting in mind will have an impact on your work. And if I'm not successful to catch your attention, there's still something to win during my talk. So I will talk about why is structured reporting important and why should you care. And I will briefly outline the content of a structural clinical fMRI report and illustrate that step by step. And if there's time, I will do a final pediatric walkthrough case, skipping more technical repetitions. Structured reporting is important to improve the neuroradiological report in terms of its rigor, conciseness, consistency, and to avoid omissions. And I want you to remember that what the clinician gets after all this effort that we've done in terms of talking to the patient prior to the exam, examining the patients neuropsychologically, testing the patient, recording the data, analyzing the data, the final point is a neuroradiological report. And it serves a communicative purpose to the clinician. And the task is to accurately convey the information. And I do believe, as a neuroradiologist, I do believe that this will increase the clinical utility of fMRI, its reliability, and also the reproducibility. And ultimately, we hope that this improves patient outcome, maybe also reimbursement, and it also has a vision for big data analysis on clinical fMRI. So why should you care? I do think having a perfect report in mind will enable you to conduct your fMRI analysis and exam even better. So what is it? What is a structured report? But a structured report has certain elements, and you can liken it to the brain imaging data structure or the neuroimaging data model as standards for organizing and reporting neuroimaging data. Saying that a neuroradiological report will all be less structured or less standardized, so it's not in the sense of being fully automated or point-click, synoptic, what some people call synoptic reporting. So your report should contain some points, but the way you handle this may be still up to your choice. And in the end, I do think that a good neuroradiological report is a piece of art. There do exist some free templates on reporting in general, like on the RSNA template library, and some hints on what could go into a report from the ASFNR, the ACR, and also in terms of the paradigms used by ASFNR. So this is what I think a good a structured neuroradiological fMRI report should contain. The thing to start with is the indication. So you need to specify whether this fMRI is performed prior to a lesion surgery, to an epilepsy surgery, to a functional surgery, meaning like cochlear implantation, or prior to revascularization, which I will cover in more detail in my talk on cerebral vascular reactivity mapping. The patient history and the condition is very important. Handedness, neuropsychological and neurological impairments, and also the comparison with previous imaging. Then if there is a lesion, you should describe the lesion location and you should describe the signal behavior of the lesion. Then you should explain what paradigm have you chosen to record the data. Why did you choose this? Was this active or passive? And whether you performed some training. You should also mention the technique of the MRI data acquisition, the pre and post processing, and the analysis and the quality assurance. And then at almost the very end, you should report your findings and observations like activation patterns, the lateralization, the spatial extent and the relation of activations and the relation to other structures of interest, displacements, and you should use very short declarative sentences here. In the conclusions and recommendations, you should, according to the indication and the question you were facing, you should give recommendations on how to proceed. For example, this could contain the surgical access, the resection attempt risks that you envision, and if you are transferring your data to the neuronavigation and when this will be ready. And at the very end, there's usually a legal disclaimer. So, indication, I'm now giving you some examples. This would be a primary indication, this is a left inferior temporal tumor. And the indication here is you do the language mapping prior to the lesion surgery for pre-surgical planning. You want to know whether the tumor contains activation. Is there function in tumor? Do you consider this tumor resectable? And how you would choose the surgical access to the lesion. And you can see here that there's one landmark, the inferior anastomotic vein of Labé, which you can render and you can set to a relation to your activation, and which is of great help to the surgeon to orient himself during the resection. And that's the same patient, and here the task is not only the pre-surgical planning, but also the transfer into the neuronavigation, which you see here, which then can help you to guide intraoperative stimulation, electrical stimulation mapping, ESM. A second indication would be the mapping of refractory, non-lesional or lesional epilepsy patients prior to surgery, and the pre-surgical language and memory lateralization. So this is a 13-year-old boy, a left-hander. He had hypermotor left frontotemporal seizures with aggressive behavior. In fact, he was primarily diagnosed with a psychiatric diagnosis, and speech was preserved during the seizures. So we conducted this exam here to assure a language dominance prior to invasive electrocorticography. Another indication which we have not touched today upon is the pre-surgical localization of a seizure onset zone. So if you have interictal pathological EEG activity, you can try to localize where this is originating from. In a way, this is different from the lesion surgery because, as we said, or the other speakers emphasized, in lesion surgery, you're primarily very often afraid of false negatives. You don't want to cut brain tissue out that causes a deficit. Cyril also mentioned that, on the other hand, of course, you don't want to limit the resection to an unreasonable degree, because the extent of resection will have an impact on survival. But of course, we want survival at a high quality of life. Here, with the false negatives are what you're afraid of in the resective surgery of lesions. If you have a non-lesional, this is of course a lesional case, but if you have a non-lesional epilepsy patient and you're trying to localize where the pathological EEG activity comes from, then this may be a different story, because if you're not punishing false positives, you will see a lot of brain regions lighting up. And then the patient in the end, if you consider this a true finding, then the patient in the end is not a candidate for the surgery anymore, because B hemispheric foci are usually not operated on. So, and then there's another finding where also you may be inclined to enforce a low rate of false positives. That is the cochlear, the implantation of, implantation of a cochlear implant. So if you do fMRI to confirm the eligibility of a patient to cochlear or auditory brainstem or midbrain implantation, you want to reduce false positive detections. This is a case where we performed, and essentially there are two ways how you can do this. People can be virtually deaf, but still show auditory responses to very loud stimuli. So you can do fMRI audiometry in the scanner. And the other thing is you can do a promontory testing. What is a promontory testing? In promontory testing, you take a wire and put it into your ear, either by perforating the tympanic membrane or by leaving it intact. And then you apply a current onto it. And that, in deaf people, that results in a hearing sensation. The first person who actually did this was Alessandro Volta. He invented the battery, and the first thing he apparently did, he took the wire and put it in his ear. And said, wow, I'm hearing something. So he would probably have been a good candidate for a cochlear implant. So cochlear implant. Now, I don't know how someone would have to click on the audio. I can't click with this. I have audio files. Can you click on the audio? I have no mouse. I only have this here.
He's working on it.
Can you click on the... Hello? Can you click on it? On the... Okay, I wanted to display... Oh, yeah. Here. Da. Click on it. Forget about it. So I want to show you that by using either active noise cancellation or omitting readouts from the EP readout train, you can induce a noise fluctuation during EPI scanning, which can be used for fMRI audiometry. This is the omission of the readout, normal readout. So this is what we can do to activate the auditory system. Of course, when you do permanent EPI scanning, you're also activating the auditory system, but it's at a constant level. So you can't detect the signal fluctuations. Another indication would be the cerebrovascular reactivity mapping. This is a patient with left stenosis of the left arteria cerebelli media. And the question here would be, does this patient require and will likely benefit from a extracranial to intracranial bypass surgery? Another indication. And then prior to lesion surgery, some people advocate to use CVRM to establish if electrical stimulation mapping is a must, because if there is a reduced cerebrovascular reactivity, like in this lesion, then you can expect any other bolt mapping, or at least that is logic, to be false negative, right? So patient history and data. So comparison with other imaging modalities and previous exams is necessary. So this is the same patient like this one. Left supramarginal tumor or space-occupying lesion. And in the spectroscopy, the lesion doesn't really look like a tumor. The choline, which is this peak here at around 3.2 ppm, is slightly elevated compared to creatine, but it's certainly not a very malignant lesion. So, in fact, I originally felt that this is a focal cortical dysplasia without a transmental sign. But then, radiology is chronology. The lesion was growing. So this couldn't be true. It's a slight grow, but you can tell here by the upper images that this lesion was getting between May 2015 and September 2017, it was getting a little bigger. So other imaging data are important. And clinical data here, handedness. Of course, you have two clinical issues that are of paramount importance. That first is that this patient is a left-hander. Second is the speech was preserved during seizures, right? And some people would probably not even consider fMRI because they would consider this clinical information so strong that you can even question if fMRI can add anything on it. And this is what I want you to remember. Even though we are doing imaging and we are very, fond of generating images, but we treat patients, not images. And this patient gets presented as something that I have written, and I ask her to read it. Can you make it louder?
Dampfvertablaterne.
So it's a one word, one
Jetzt schreiben Sie
word.
das
She
bitte
chops
mal
it up.
runter.
And now I ask her, so she can't really read it. I ask her to write it down. And as you can see, when she gives me the paper back, the word is it's a German word, Dampfvertablaterne.
Haben Sie keinen Fehler gemacht. Ich zeige das mal hier
So
noch.
she writes it perfectly, but she can't read it.
Da sehen Sie auch, was Sie da. Das
Okay?
lesen Sie
And this is
zuerst mal vor.
post-operatively, the same thing. So there are patients who obviously can't read, but still can write, which is very peculiar. And sometimes these people even improve their reading by writing. So this is my first poll. What would you think where this lesion is located? I give you some more information. The patient also had what we call color anomia. And she had a hyperfamiliarity for faces. She has no dyscalculia, she has no agraphia, and she has no hemianopsia. And now we are doing radiology without taking a single image of the patient. Give your pulse now. Right. So some people vote for the splenium. But this is a very fair count, very, very well done by you. The splenium would not explain the color anomia, and it would not explain the hyperfamiliarity for faces. But it's a left, and I should have said that she's a right-hander, left posterior lateral inferior temporal lesion. Next slide. Oops. This was the lesion of this patient. And this patient that I've shown you before showed the same after the surgery. When he woke up from the surgery, he was holding his mobile phone and getting text messages from his family and his spouse. And he could not read it, but he could type saying, "I don't know who's writing me and what you're asking, but don't worry, I'm fine." Wow. And the cool thing is that I predicted that this is going to happen and that he would recover, and he did recover. So a major thing for our report is we need to say where the lesion is and how does it present. And now you can win something. So you need to tell me whether this lesion is intra or extra-axially, and sometimes this is very hard to tell. And what does intra-axially mean? Intra-axially means inside the brain parenchyma. It does not talk about which cells generate this lesion or whether these are primary senescence cells, or it could be a metastasis, but it's inside the parenchyma. So what would you think? Here's the lesion. The first one who gets this right gets the present. Let's get a little. So try hard. Have you made up your mind? You get more images. What do you think now? Intraaxial, extraaxial. Any ideas? What? Intra. Why I'm showing this? This is suspicious. There's a little nodule at the dura in front, and there you see the whole thing abuts to the dura. In the end, it was both. It was the rare case of a metastasis into the meningioma which invaded the brain parenchyma. But not bad. You will get the present. So in terms of the lesion description, it's important to note signal drop, because such signal drop can be, like from flow voids in AVMs, can be excluded from automatic brain masking. And I've seen papers where people said, oh, we did like a study on AVMs, and there was never any activation inside of the AVM. But when they exclude the AVM from the inclusion mask, then this is what you would expect to happen. And if you have no signal, you can have you cannot measure fMRI activations or reconstruct tracts. This is a cavernoma with intracellular methemoglobina, which is bright on T1 but dark on T2 and T2 star. And when you now look at the signal, the fMRI signal outside of the lesion, you see that's the fMRI signal and that's the diffusion signal. And inside of the lesion, you have a dramatic drop. So this is 1.8, that's like 20,000, almost 20,000 signal. And it's like 300 absolute signal in the diffusion. And now you're dropping down to 15 and here to 1,000. So if you don't measure signal, well, false negatives are, it's prone to generate false negatives. Parasum dime selection, I'm going to skip that because I think I'm running out of time and the others have covered that to a fair degree. So the point is, fMRI activations are variable and should be evoked optimally. There's no point if the patient cannot follow the paradigm, and I like what Michael said, that you tailor your paradigm to the lesion location. That's very important. That's a very important thing. And this was just to show that even what we consider as one area, like the inferior frontal gyrus, that it has structure in it. Like there's what I call a phasotopic organization within a structure. And this is to show that also structures of the skull may be important. Here the coronary suture may be important for the surgeon to plan the access. Then technical stuff about your data acquisition. First, we notice, can you click on this? I want to wake people up again. Hello? They're gone. Okay, I wanted to present to you active noise cancellation. Can you click on the... No, you have to, can you click on this? I know how to forward my slides. Here. Whatever, forget it. You can use active noise cancellation, which lowers the EPI noise. Okay, so the you can use active noise cancellation to make it to so, and that's obviously a good idea. And then another good idea to do is to sample your data relatively fast. You see that on top you have a regular sequence with a TR of 3.0, and then below you have a sequence with a TR of where the TR was doubled, so the temporal sampling, the TR was half of it, so the temporal sampling was doubled. And you see for one that the correlation with your paradigm, which is only 0.2 here, goes up to 0.7 for the faster sampling, and the statistical confidence of your results will improve. So you should mention at least repetition time, echo spacing, so that's probably, and the spatial resolution of your sequence in your report. And then it's important to say what did you do to your fMRI data. We already talked about this. So smoothing fMRI data can both smear out your activations, but also extinguish or throw away other activation. Look at the dot of the eye. Smoothing by a relatively moderate kernel gets rid of this dot on the eye. So smoothing is something difficult, and you need to know if you're happy to do it or not. So any resective lesion surgery where the spatial relation of the lesion with the activation matrix, the smoothing is probably giving you a headache. Distortion corrections, this is a patient with a reservoir, and you see this is not functional EPI, but diffusion EPI, which is essentially the same, aside from the fact that the diffusion EPI usually uses spin echo EPI, which does not suffer from the additional signal loss, but only the distortions. But the distortions can shift your activations by easily 3 centimeters in patients with such catheter material. And here, functional to structural misalignment, here you would be wondering, is this intratumoral activation? Can you operate on this patient? But it was not, it was just Z shift, what the inferior superior shift that Mark Jenkinson was mentioning. Data analysis, briefly, your results, aside from the Sarserding, your results can vary greatly. These maps were both generated by Gaussian gamma mixture modeling and thresholding at a true positive probability of 50%. On the left, you see the results, the Z statistical map from the GLM was thresholded, and on the right from the ICA. So that really shows you that you need to select the most proper data analysis for your purpose. A good neuroradiology report takes courage, and the courage to be potentially wrong. So here, conclusions will depend on your analysis and the statistics. This was a 5-year-old boy, where the question was if this lesion, which was a focal cortical dysplasia, you see the transmental sign here, the bright T2 bright signal going to the ventricle. So the question here was, is this lesion active? And if you would do a regular GLM analysis protected against false positives, so your false positives rate is less or equal than 5%, you would say, okay, I could probably cut out most of this lesion. But doing mixture modeling or ICA-based analysis, you see that this lesion was active, and you should not, resection is not feasible. In this case, resection was feasible and performed because there were no intratumoral activations. This was all feigned by Z-shift. And fMRI can't tell which, and that's very important, it can't tell which blobs are dispensable or indispensable, but you can validate this by ESM. So if you transfer your results into the neuronavigation and you tell the neurosurgeon, this is the region where you want to do the electrical stimulation, then this can be the impact your fMRI exam has on the final outcome and on performing the surgery. Here, the conclusion was, this was the 13-year-old boy, and the fMRI task was description cued word generation. So what does King have on his head? A chrome. And when you perform ICA, you get two components. One component which is strong lateralized and one component which is not very strong lateralized. And the strong lateralized component, if you look at the activation probabilities, it matches extremely well with the surface projections of the connective probabilities of the arcuate fasciculus. And that's why this case was felt to be right brain lateralized for expressive speech. And here, this is about the final slide. Here, we were able to resolve an inverse localization error, which was from the EEG. The EEG localized the focus of the pathological EEG activity to the right hemisphere. But fMRI showed that this is probably the intra- and tumoral region is probably where the seizures were generated. And one poll for you. So this is a 20-year-old lady, and the indication was, the question is this lady a good candidate for cochlear implantation? She had a motor vehicle accident on Christmas Eve, and due to diffuse axonal shearing injuries, she was deaf. What we did first is we did the fMRI audiometry, and we only saw activations in the right hemisphere. So this is radiological convention. Then in blue, we did a left promontory testing, and we confirmed excitability of the right auditory cortex, and we show that at the level of the collicular plate, there was a bleeding from the shearing injuries, which interrupted her auditory pathway to the left auditory cortex. So the question for you now is, A, can she benefit from a cochlear implant? And B, what ear should be implanted? So could you vote? Excellent. Okay. That's it. Most people say right ear should have the cochlear implant. Remember, finished? It's the right auditory cortex that shows the response, and the auditory fibers cross by 75%. So the correct answer would be, yes, she can have a cochlear implant, but the left ear should be implanted in the left ear, not in the right. If you put it in the right ear, she has no chance to restore her hearing. Okay, and in this case, I will cover in my other talk, and I think it's too late for the walkthrough case.
Okay, thank you. Okay, we have a question from the audience. If an fMRI researcher is not an expert neuroradiologist, would you recommend that he or she mark the tumor and overlay it on the fMRI report or not?
If the person doing the fMRI is not a neuroradiologist.
Is not a neuroradiologist. Okay. Would you recommend that they mark the tumor?
Yes, I would say. The thing is, I think fMRI is really an interdisciplinary action. And I have no problem in people from psychology, neuroscience, conducting clinical fMRI exams. But I think it would be good if the neuroradiologist checks the images and marks the tumor, or also looks for if there's a secondary lesion, because this can dramatically change the conclusions. And you should probably do it beforehand. Because, like, for example, if a glioblastoma has already shown signs of subepidermal spread, you may discuss the necessity to perform any resection. So, yes, I think a neuroradiologist should be involved.